Hello everyone, this is Dr. Bhanjan Saho. This is my third video on preoperative evaluation. Preoperative evaluation. The preoperative evaluation has several components and goals. One should review the available medical record and obtain a history. Perform a physical examination pertinent to the patient and surgery. On the basis of the history and physical examination, the appropriate laboratory test and preoperative consultation should be obtained. Then ASA physical status of classification. ASA 1 a normally healthy patient, healthy, non-smoking, no or minimal alcohol use. ASA 2 a patient with a mild systemic disease only without substantive functional limitation, current smoker, social alcohol drinker, pregnancy, obesity, BMI less than 40, greater than 30, well controlled diabetes and hypertension, mild lung disease. ASA 3 is a patient with a severe systemic disease, substantive functional limitation 1 or more, moderate to severe disease, poorly controlled diabetes or hypertension, COPD, morbid obesity, BMI greater than 40, active hepatitis, alcohol dependence or abuse, implanted pacemaker, moderate reduction of ejection fraction, ESRD, undergoing regularly scheduled dialysis, history greater than 3 months of MI, CVA, TIA or CAD or stent. ASA 4 is the patient with severe systemic disease that is constant threat to life. Recent less than 3 months of MI, CVA, TIA or CAD or stent, ongoing cardiac ischemia or severe valve dysfunction, severe reduction of ejection fraction, shock, sepsis, DIC, ART or ESRD, not undergoing regularly scheduled dialysis. ASA 5, a morbid patient who is not expected to live. Ruptured abdominal, thoracic aneurysm, massive trauma, intracranial bleed. Then Malampati classification: class 1, class 2, class 3 and class 4. Class 1 is the, you can see uvula, fauces, soft palate and pillars are visible. Class 2, uvula, soft palate, fauces visible but pillars are not visible. Class 3, base of uvula and soft palate visible, and class 4 only hard palate is visible, which is the area management is very difficult. ASA fasting guidelines. There are preoperative fasting guidelines and pharmacological interventions for the prevention of perioperative aspiration. The guidelines specifically deal with the healthy patients of all ages scheduled for elective procedure where general anesthesia, regional anesthesia or sedation will be administered. Adult has kept nil per oral for 6 hours for semi-solid and liquids and 2 hours for clear fluid. Pediatric patient has to be kept nil per oral 6 hours for non-human milk or infant formula, 4 hours for breast milk, 2 hours for clear fluid. Drugs that has been used to decrease gastric fluid in an effort to reduce the risk of aspiration pneumonitis, that is histamine 2 receptor antagonistic, proton pump inhibitor, antacids, antiemetics and a gastrocogenitive agent. They are not prescribed for every patient but is recommended only in patient with a high risk of aspiration. Preoperative medication. A preoperative sedation, benzodiazepines are the most used for decreasing anxiety, producing amnesia and sedation. For example, midazolam 1 to 2 mg intravenously, diphenhydramine. Opioids best drug is fentanyl. For this, that is given as 1 to 2 mg per kg body weight intravenously. Anticholinergic drugs, atropine, glycopyrrolate and scopolamine. Indication: anticialog glycopyrrolate, sedation scopolamine, amnesia or vagolytic atropine. Continuing current medication. Drugs to be continued: antihypertensive medications, all are continued, even angiotensin converting enzyme inhibitors and angiotensin 2 receptor blockers. Cardiac medication: beta blockers, digoxin, statins, antidepressants, anxiolytics and other psychiatric medications. Thyroid medications, anticonvulsant medications, asthma medications, steroids, aspirin, other routine medication which is not instructed to discontinue. Drugs that should be discontinued on the day of a surgery. Drugs that should be discontinued on the day of surgery are oral hypoglycemic agents. Warfarin discontinued 4 days before surgery except for patient having cataract surgery without a bulbar block. Thienopyridines, for example clopidogrel and teclopidine, except in cataract surgery patient with metallic or drug-eluting stents. Low molecular weight heparin 12 hours prior to surgery. Tricyclic antidepressant stopped 3 weeks prior to surgery. Lithium is stopped 24 to 40 hours prior to surgery. Drugs to be stopped before surgery: Viagra before 24 hours of surgery, warfarin 4 days before of surgery, aspirin continued, clopidogrel stopped 5 days before, ocipil high dose of estrogen stopped before 4 weeks, herbal medication before 1 week, smoking before 8 weeks. Drugs morning dose omitted before surgery, ACE inhibitors and ARB increase risk of intra of hypotension. Diuretics except thiazide. Topical creams may have skin reaction, OHA or oral hypoglycemic agents for all kind of surgery. Drugs dose modification before surgery. One is cholinesterase inhibitor, that is neostigmine or pyridostigmine, which are used for myasthenia patients. So if stopped, myasthenia crisis; if continued, antagonize muscle relaxation. Hence continue with reduced dose. Steroids. History of intake greater than 3 weeks in last 1 year by any route, then supplement with the perioperative steroids. Antitubercular therapy. Only stopped if LFT are compromised. Fluids. In intraop, fluids are used for maintenance and replacement. Maintenance formula is 4 to 1, that is 4 ml per kg body weight up to 10 kg, then 2 mg per kg body weight 10 to 20 kg, then after 20 kg then it is 1 ml per kg body weight. And fluid of choice is ringer lactate. Also replacement fluid of choice is ringer lactate. Goal directed therapy in pulmonary edema and cardiac failure patient. Fluid therapy should be directed by parameters as best is stroke volume variation measured by echo. Second best is pulse pressure variation measured by radial artery cannulation. Third is central venous pressure. Monitoring. CNS monitoring. Neuromuscular monitoring. The neuromuscular junction is monitored in order to determine onset and recovery from pharmacological neuromuscular blockade. Principle. A supramaximal electrical stimulus of between 10 to 15 milliampere is applied to accessible peripheral motor nerve, for example ulnar nerve, facial nerve, or the response of the appropriate muscle group is assessed either clinically, mechanically, or electromyographically. Type of stimulus, that is single twitch or train of 4 twitch delivered at 2 Hz. Titanic stimulus of duration not more than 5 seconds. Double burst stimulation. Application of stimulation is painful and should not be carried in outpatients. Monitoring depth of anesthesia. There is a dire requirement of a monitor which might reflect the conscious levels of patients undergoing general anesthesia. Most of these monitors are based on electrical activity of the brain. They are generally work on two principles: spontaneous electroencephalography or provoked EEG to auditory evoked response. Depth of anesthesia is monitored by BIS index by bispectral index. 0 is brain dead, 100 is fully conscious, and 40 to 60 adequate depth. Second is entropy. Assessment of a neural integrity. Evoked potential monitoring, a non-invasive monitor for neural pathways, spinal cord or nerve roads. Somatosensory evoked potentials. The incidence of neurological damage during spinal cord surgery can be minimized by monitoring somatosensory evoked potentials and motor evoked potentials. Assessment of cerebral flow. Adequacy of cerebral flow can be measured by a number of monitoring techniques, that is transcranial Doppler ultrasonography, EEG, SSEPs, jugular ball oximetry, cerebral oximetry. Monitoring of arterial oxygenation by pulse oximetry. Principle. Pulse oximetry measures pulse rate and estimates the oxygen saturation of hemoglobin on a non-invasive continuous basis. The oxygen saturation of hemoglobin as percentage is related to the oxygen tension by the oxygen hemoglobin dissociation curve. Oxygen saturation is determined by spectrophotometry, which is based on the Beer-Lambert law. At constant light intensity and hemoglobin concentration, the intensity of light transmitted through a tissue is a logarithm function of a oxygen saturation of hemoglobin. Two wavelengths of lights are required to distinguish oxyhemoglobin from hemoglobin. Light emitting diodes in the pulse sensor emits red 660 nanometer and near infrared 940 nanometer light. The percentage of oxyhemoglobin is determined by measuring the ratio of infrared and red light sensed by a photodetector. Pulse oximeter performs a plethysmographic analysis to differentiate the pulsatile arterial signal from the non-pulsatile signal resulting from venous absorption and other tissues such as skin, muscle, and bone. Factors affecting the accuracy. Factors affecting accuracy are these hemoglobins. For example, methemoglobin absorbs red and infrared wavelengths of light in a 1:1 ratio corresponding to an SpO2 of approximately 85%. Therefore, increase in methemoglobin produces an underestimation when SpO2 greater than 70% and an overestimation when SpO2 less than 70%. Dyes like methylene blue and indocyanine green, nail polish, ambient light, hypotension, hypothermia, electrocentric. Capnography. The measurement of carbon dioxide in respiratory gases is known as capnography. Capnogram. It is a continuous concentration time display of carbon dioxide sampled at a patient's airway during ventilation. The capnogram is divided into 4 distinct phases. First phase A to B is called depending on the initial stage of expiration. Gas occupying anatomical dead space devoid of carbon dioxide represents this phase. Then second phase B to C represent the sharp upstroke when carbon dioxide containing alveolar gas is represented by sampling site. And third phase is C to D represent the alveolar and expirator plateau. Fourth phase is D to E. Inspiration begins and fresh gas is entertained and touches the baseline. Phase C to D may take an upward slope. C to D. Point D is the highest carbon dioxide value and is called end tidal carbon dioxide EtCO2. Is the best reflection of alveolar carbon dioxide. Normal value of EtCO2 is 35 to 45 mm per Ag. Capnography. Sudden loss of wave from ET tube disconnected, dislodged, kinked or obstructed, loss of a circular function. These waveforms are formed. Decreasing EtCO2, ET tube cough leak, ET tube in hypopharynx or partial obstruction. These are the waveforms. If CPR assessment attempt to maintain minimum of 10 mm Ag, these are the waveforms, and sudden increase of EtCO2, return of spontaneous circulation is bronchospasm, that is called shark fin appearance, asthma, COPD, hyperventilation waveforms, and decrease EtCO2, apnea or sedation, and these are the waveforms. Clinical application of capnography. Carbon dioxide is produced in the body by cellular metabolism, conveyed by the circular system to the lungs, excreted by the lungs, and transmitted by the breathing system. Therefore, changes in respiratory carbon dioxide may reflect alternation in metabolism, circulation, respiration, the airway, and breathing system. Normal end expiratory carbon dioxide partial pressure ranges between 35 to 45 mm per Ag. Malignant hypothermia is a hypermetabolic state with a massive increase of carbon dioxide production. The increase occurs early before the rise of temperature. Early detection of this syndrome is one of the most important reasons for routinely monitoring carbon dioxide. Capnography can be monitoring the effectiveness of treatment. Factors affecting EtCO2, causes of elevated EtCO2, metabolism, pain, hyperthermia, severing, respiratory system, respiratory insufficiency, respiratory depression, COPD, analgesia or sedation, circulatory system, increased cardiac output, medication, bicarbonate administration. Causes of decreased EtCO2, metabolism, hypothermia, metabolic acidosis, respiratory system, alveolar hyperventilation, bronchospasm, mucus plugging, circulatory system, hypotension, sudden hypovolemia, cardiac arrest, and pulmonary emboli. CBC monitoring. Most basic CBC monitoring is pulse rate and blood pressure. Pulse rate measured by pulse oximeter, BP by NIBP in intervals. The NIBP intervals must be in 2 to 5 minutes, not more than 5 minutes. Invasive BP for continuous monitoring, radial artery, mostly cannulated, gold standard. ECG only 2 leads, 2 or V5 monitor, 2 arrhythmia, V5 is for ischemia. Echocardiography single most best monitor for assessing cardiac function is TE, transesophageal echocardiography. Most important determinants of morbidity mortality are left ventricular ejection fraction and pulmonary artery pressure. Very sensitive, can detect 99% of ischemic events. Temperature monitoring, most accurate is core body, side cell most accurate core body pulmonary artery. Most commonly used is lower end of esophagus. Thank you.